part one, which is triage. Life-threatening illnesses and triage is what you're going to learn tonight. How many of you are familiar with triage? Okay, does anybody not know what that is? If you don't, you will by the end of the night. You'll have to do it and you'll be experts. Okay, again, personal safety, top priority, right? Do the most good for the most number of people. That is really what triage is all about, doing the most good for the most number of people in the shortest amount of time. Triage and search and rescue. That's where we really focus. We're going to talk about the killers, and we're going to, the three killers, there are three of them, and they happen to be in the second bullet point. So obstructed airways, uncontrolled bleeding, and shock. Those are the three killers. So we're going to learn how to deal with those right up front, because those are the things that put people in danger the quickest. And then we're going to learn, and that morphs into triage. So it's kind of how we start triage, and then we're going to learn how to actually do triage. So, approach the patient. First of all, I'm going to focus on the gloves next in the second medical, because that's when you're really going to start doing hands-on stuff. So I'm not going to focus on gloves tonight, but whenever you are dealing with patients, when you're doing triage, anything, you're touching anybody, just remember you should always be wearing medical gloves to do that. We're not going to do that tonight, because we're not going to do a lot of touching each other, but next week we're going to do a lot of that. So approaching a patient, remember size up. Size up is just looking around, scene safety, your personal safety. Are you safe in doing whatever it is you're going to do? If you were to come across an accident on the freeway, before you jump in to help somebody, make sure that you're looking what has gone on around. Are there power lines? Is there anything that you need to worry about? So you just make sure that the scene is safe for you, and your personal safety. Make sure the victim sees you if they are conscious. So introduce yourself. It says identify yourself, ask for permission. So if the patient is conscious, you do need to get their permission to treat them. And that is not to say that you have to say, is it okay if I help you? Can I have your permission to help you? You don't need to do that. You can simply make a statement. I'm here to help. Right? That's all you need to say is, I'm here to help. Give them an opportunity to say, get out of my face, I don't want your help, leave me alone, right? They have the right to say that, and if they say that, walk away, right? Your safety is number one. You're not going to get into a fight with them to try to help them. If they don't want your help, leave them alone, don't help them. Children cannot refuse treatment, so they don't have that luxury, but a parent or guardian nearby can refuse that treatment on their behalf. So just remember that. If you see that somebody is in really dire straits and they're, on the verge of passing out, but they're still telling you, I don't want your help, I don't want your help.
Wait till they pass out.
Wait till they pass out.
Right.
Just kind of stand back, say, okay, I won't help you. And then when they go down, you can now help them. Because at the point that they lose consciousness, the concept is called implied consent. Even though they had told you no before, once they're unconscious, it's implied consent. So anybody that you approach who is already unconscious, it's implied consent and you can treat them. Respect cultural differences. Just make sure that you're able to communicate with the person that you're trying to help. There may be a language barrier. Do the best you can to communicate with them. And the biggest cultural difference that we have really is when it comes to touching. There are a lot of cultures out there that just they don't want to be touched. They don't want people to touch them, and they're very sensitive to touch. It is very difficult to help somebody without touching them. You have to touch them to help them. But what you need to do is, especially if they're conscious, you need to make them a part of it. Let them know where you're going to touch them, why you're going to touch them. Make them a part of it so that nothing is coming as a, don't just start grabbing at them, right? Just let them know everything that you're doing and why you're doing it. And just make them a part of it, and they'll be a little more accepting of that if they know what it is that's going to be happening to them. Phases of death from trauma. So there are 3 phases of death. It's when death will occur within minutes, when death will occur within hours, and when death will occur within days. And the things that are listed underneath are usually the leading cause of those particular phases. So shock, excessive immediate bleeding, heart attack, those usually cause death within minutes. Poison is the #1 cause of death within hours. Substantial and prolonged bleeding that's not controlled properly will cause death within hours, and a lack of oxygen. That doesn't mean no oxygen, it just means difficulty for somebody to breathe and get the proper amount of oxygen that they need. And death within days, infection, dehydration, hyperthermia or hypothermia, and you'll learn more about those in 2 weeks. So when we look at this, we can start to understand triage a little bit when we look at these phases, because when you look at these phases, it would make sense to you that we would want to pay a little more attention to somebody who we think might be in phase 1, right, before we pay attention to the person who we think might be in phase 3, right? That makes sense, right? So that's what, when we learn triage, that's basically what we're doing. We're trying to identify who is at greater risk of death more quickly if we don't get them the appropriate treatment, and who can wait a little bit longer. I will repeat it over and over again. When we do triage, at no point are we ever saying that somebody does not need help. Everybody who is a victim of something needs help in one way or another. All we are trying to do is say who can wait a little bit longer than others to get that help. Okay? So the 3 killers: airway obstruction, excessive bleeding, and shock. Those are the 3 things that we have to prioritize. And disaster medical operations, that is what we look at first. So our first priority is open an airway. If somebody's not breathing, we need to open their airway. What do we think would be the easiest table to clear off of everything that's on it? Yeah, we're back. Only 2 people sitting there. Yeah. So we're going to clear that table off momentarily, and just for a few minutes. So our first priority in disaster medical operations is open the airway. We also need to control excessive bleeding, and we need to treat for shock. Those 3 things. So we're going to take those 3 things one at a time. So airway obstruction. Our tongue is the most common airway obstruction that we have. Does anybody in here snore or would care to admit to snoring? So if you snore or your partner snores, that is the tongue relaxing and blocking the airway. And it can become very serious. Does anybody know anybody with sleep apnea?
My husband.
Yeah, very, very serious. That is somebody whose tongue is constantly blocking the airway, and it makes it difficult to breathe. I mean, you can't breathe if your tongue is just this big muscle that sits in your mouth. And when you're laying down, it's usually when somebody's on their back and they start to snore, it's because that muscle has relaxed. They're sleeping, so the muscle relaxes, and the tongue sits back and blocks the airway, and that produces the snoring. So usually when you hit them or knock them over, turn them on their side, the snoring stops until they roll back over again, go back to sleep, and then the snoring starts.
So how does that mask work that they have to wear?
I am not sure how that works, but do you know, since they use this one?
Well, it uses a positive pressure. It does positive pressure to keep it
Pushes it in.
Yeah, positive pressure.
Right, they have the nasal one, which is more comfortable now.
Yeah, they've come a long way with treatments for it. Most of us who snore, it's just an obnoxious snore. I snore too, to the point where my husband won't even sleep in the same bed with me anymore because I keep him up all night. Between that and grinding my teeth, I also grind my teeth, so I give him a double whammy, snoring and grinding my teeth, and he can't stand it. Can you swallow your tongue? Can you swallow your tongue?
What about epileptics? I was saying.
Probably.
I believe you can.
You cannot, unless you chop it off.
50-50.
Chop it off, right? But it is connected, so you cannot swallow your tongue.
Seizures, you can definitely bite them.
They're not, they can't swallow their tongue. But they can obstruct their airway with it. They can obstruct their airway. And we'll talk more about seizures when we talk about treatment in 2 weeks. We'll talk a lot about seizures.
May I say something on
Yes.
that airway obstruction? I had one that elderly, she was really going a straight line, but she had swallowed her denture or partial, it went down and obstructed her airway.
Ooh.
It must be loose or something. And that's what caught, we didn't know at first, we were doing the CPR, and then we said, oh, let's check them out, There was the, her denture, that was way down there.
Why didn't anybody remind me?
Oh, well,
Now everybody's gonna get 4. Because if you don't remind me, you get more.
yeah, right. Extra one.
Okay, so we cannot swallow our tongues. We have this saying that don't assume anything, right? You never assume anything, because what happens when you assume anything?
You and me.
There you go.
Yeah, you got it.
There you go.
So when you,
Water right in front of your camera.
I know it's probably on the seizure thing, but I remember a kid in high school having one, and they said, obviously to clear his tongue through his throat, so he wouldn't, gasp on it or something.
I'm sorry, I missed that.
The guy had a seizure, and they said, he was on the ground. They said,
All of this is not in your manual. They took it out of the manual. And in the manual, the only option they present to you is called the jaw thrust. So you're familiar with the jaw thrust, right? Okay. So, yes.
Can you go back and take a picture?
Oh, yes, absolutely. In a disaster, this is preferable because you have a way to walk away from that person, right? And leave their airway open. The problem with this is that you are going to have to reposition your patient on their back in order to do a head tilt chin lift. And if they had some sort of spinal injury, you could exacerbate that injury by moving them, right? But if you don't move them and they're not breathing, they're dead. So what do, right? Do you hurt them possibly, but give them a chance to breathe? Or do you leave them not breathing and they're dead? Okay? When we watch you give them a chance to breathe, right? So the jaw thrust is a way that if you suspect a spinal injury in somebody and you don't want to move them, you think you're going to break their back or something, the jaw thrust can open an airway in whatever position that patient is found. So you don't have to get them onto their back. They can be on their side. They can be whatever position they were found in, and all you need to do is thrust their jaw. And to thrust their jaw, it's difficult. It's difficult for a lot of people to do. It hurts the person that it's being done to. You can kind of do it to yourself, get the idea. You're not going to fully thrust your jaw, but the idea is to, from this position back here, to thrust forward. And you're taking the whole bottom part of their mouth and bringing it forward. And when you do that, it opens the airway. The problem with the jaw thrust is, like CPR, it's a commitment. You can't thrust somebody's jaw and then let it go, because it'll go right back to that position and it'll block their airway again. So I don't understand why they put the jaw thrust maneuver in there, and why they went with this as opposed to the head tilt chin lift. Because if you take the time to thrust somebody's jaw, you have to stay with them and you have to keep that jaw open. And it's a more difficult job to try to give somebody else to do, because it's not easy to thrust somebody's jaw. And a lot of people just plain can't do it, right? I mean, it's hard to do if you don't know what you're doing. So we prefer the head tilt chin lift. But it does go in the manual, it does go into detail. detail on how to thrust and the position, where to place your hands and all of that. Yes?
Question, is there any truth to putting somebody on their side if you have to walk away? Is that being a better choice?
Well, it depends, okay? The more you move somebody around, the more likely you are to exacerbate any injury they might have, right? If you had to get them onto their back for a head tilt chin lift, I wouldn't then move them again to put them into what we call the recovery position. There is a time and a place to put people in the recovery position, and yes, it does help to keep that airway open. If you place somebody on their side in the recovery position, and you will learn the recovery position in 2 weeks during treatment, it does help, yes. But you have to be sure about who you're putting into the recovery position and that you're not going to injure them further. That help?
It does.
Okay. All right. Positioning a conscious patient. If they're on a chair, legs shoulder width apart, elbows or hands on knees, leaning slightly forward, and when they're standing, they should basically be standing in this sort of position, right? With their hands on their knees. Arms straight and lean forward with a flat back. Always allow the patient to put himself or herself in a position of comfort. Don't force them to be in a position that is not comfortable for them. So let them decide what their position of comfort is. Bleeding. Now we're going to get into bleeding. And we're going to see, is there anybody here who is sickened by the sight of blood? Okay, good. Because you're going to see some in the video. Arterial bleeding. Arterial bleeding is the most serious bleeding that there is. It represents the greatest loss of blood in the shortest amount of time. It is very recognizable. It is bright red. It is spurting, right? Because you nick an artery. They're transporting blood under high pressure, so you nick that, and the pressure is released, and the blood just spurts out. Venous bleeding and capillary bleeding, those are both transporting blood under very low pressure. So venous bleeding will be more of a flowing type of bleed. It won't spurt out, it'll just constantly flow. And then capillary bleeding, like on your hand or your fingers or something, the blood will come out and just kind of ooze right at the area where it came out. So it's spurting, flowing, and oozing. All bleeding needs to be controlled, and all bleeding is dangerous. It's just that arterial bleeding is the most dangerous and needs to be controlled the quickest. So there's a little picture of arterial, venous bleeding, and capillary bleeding. So you can kind of see the spurting, the flowing, and the oozing, right? Good? Okay. Controlling bleeding, you obviously need to find the source of the wound. You need to cover it and apply direct pressure. And pressure is pressure. It's pressure. It's hard. And it could hurt the person that the pressure is being applied to, but that pressure needs to be applied in order to get that bleeding to stop. Okay? For disasters. Do you guys are you a retired nurse or? Okay. What are your thoughts on elevation?
Depends on how much blood is coming out.
Yeah, so the Red Cross has almost completely removed elevation from bleeding control. We keep it in here because we are talking about the really bad day. We are talking about, not having resources, not having those medical resources, not having the doctors at the hospitals that can tend to you in a quick manner. And we need to find a way to control bleeding. I mean, we just really need to find a way to stop bleeding. So we keep elevation in play for that purpose. So direct pressure, if the wound is here, direct pressure and elevation. And elevation is above the level of the heart. We want blood to go this way, not that way. So we want it to, if it's the legs, elevate the legs, right? The only time you're not going to elevate legs, whether it's bleeding, you just have to stick with pressure, or in treating for shock, we'd say to elevate the legs, but the only time that you're not going to elevate somebody's legs is if they have a bleeding head wound, because we don't want blood, they're already losing a whole lot of blood. Heads are one of those things where does all that blood come from? Because they bleed forever. I mean, there's a lot of blood there. Pressure points. When you apply direct pressure and elevation, the combination of those two will probably stop, I would say, about 95% of all bleeding wounds. The combination of direct pressure and elevation. Now, one of the questions I get asked is how long does it take for bleeding to stop? And it's a fair question, but it's a question that doesn't really have a solid answer because it depends on the person, right? Everybody is different, but you can't put pressure and elevate and expect bleeding to stop in 30 seconds. It just doesn't happen that quickly, right? It could take 5, 6, 7 minutes for bleeding to stop. So don't expect that you're going to see, you apply pressure and then the bleeding just miraculously stops. It doesn't happen that way. You have to give it some time to stop. When elevation and pressure points are enough, or when direct pressure and elevation aren't enough, then we can add to that pressure points. And pressure points are in the upper arm, and you can feel it, right? If you press in on your upper arm and you feel a pulse there, and then you press in and you press in and you hold it there long enough, your fingers will start to tingle because you're cutting off circulation, right? You're stopping that blood flow. So that's the pressure point for arm wounds. You would use the pressure point, the brachial pressure point. There's a femoral pressure point, you can all find it for yourselves, in the groin area, okay? And then you have another pressure point that I just call behind the knee, because I don't like its technical name. It's like popliteal, yeah. So I just say behind the knee, that's easier. So that's another pressure point that you have. When you add pressure points to direct pressure and elevation, you are now probably going to be successful in stopping just over 99% of all bleeding wounds, okay? As a last resort, in the disaster world, when you have tried everything and you cannot get bleeding to stop, you are going to have to apply a tourniquet. Tourniquets have made a remarkable comeback. Tourniquets are being used on a daily basis now by firefighters. They go out to car accidents, motorcycles, they just put a tourniquet on. It's almost the first thing that they do is put a tourniquet on. And that is fine because that patient is going to the hospital and it's getting dealt with right then and there. That tourniquet's not going to stay on for hours and hours and hours. It's going to be dealt with. So tourniquets are very, very useful. But in the disaster world, it can't be your go-to choice because it's going to be on for too long and there's not going to be a way to save the limb once it's on for too long. So tourniquets in the disaster world, when you don't have those ambulances, you have 500 people waiting to be seen at a hospital, tourniquets have to be considered by you to be the last resort, a matter of life or limb. If they're going to bleed out, apply a tourniquet. But you have to try every other way to get bleeding to stop first. Just do everything you can to save that limb.
I have a question.
Yes?
So you're saying basically we're going from the simplest to the most complicated, pressure point being one before tourniquets. If you're doing pressure points and you need to see other people because there's a disaster, how do you keep that pressure point?
Okay.
Because it's similar to a tourniquet.
Exactly. So here's the thing. During triage, and we will go over this when we do triage, this kind of stuff isn't going to be done during triage. During triage, you just need to find a way to stop the bleeding.
Okay.
It could be grabbing somebody's scarf, handkerchief, a jacket, wadding it up, giving it to a bystander, putting it on the wound and saying, just hold pressure here, just hold pressure. And don't let go. Just hold pressure, don't let go. And then you move on and you triage everybody else. When they get to treatment, that's when you're going to focus on their bleeding wound. And they're going to bandage it, you're going to watch it, you're going to make sure it's not continuing to bleed. During triage, you're probably not going to be applying a tourniquet. unless it's really, really serious and it's arterial and you know it and they're just losing way too much blood. So we will, let's look at tourniquets. Again, life or limb, right? Matter of life or limb. If you end up having to put a tourniquet on somebody, when I was a Girl Scout growing up and learned all about tourniquets, it was 20 minutes on, 20 minutes off, 20 minutes on, 20 minutes off. That is out the window. Once you put a tourniquet on somebody, you don't loosen it, you don't remove it, you don't do anything. You just leave it right where it is. You just leave it. If for some reason the bleeding hasn't stopped, it is probably because you did not apply the tourniquet tight enough to stop all that, the pressure. And in that case, you need to apply a second tourniquet. You don't loosen the first one. You don't, if you have room above the first one, you put it above. If you don't have room above it, put it just below. But you're going to add. You're not going to loosen. You're not going to do anything to the one you put on wrong. You're going to leave it there, and you're going to add a second one and make sure that you do that one tighter than you did the first one. Because if tourniquets will stop the bleeding. There's no question. That is what stops the bleeding. Okay? And it kills over time. It just kills the rest of the limb. There are only 4 places that tourniquets are applied. Upper right arm, upper left arm, upper right thigh, upper left thigh. Okay? As high as you can. Okay? There used to be a school of thought to put the tourniquet between the wound and the heart, as close to the wound as possible. So for example, if the wound was here, then put the tourniquet here because it's, you know, close to the wound, but it's between the wound and the heart. And the thinking there was that the tourniquet, where you place the tourniquet, represents the point of amputation. So why put it way up here and have them lose their whole arm when you can put it here and they only lose this much of their arm, right? This is a really bad place to put a tourniquet because you've got 2 bones here, right? So you really want to put a tourniquet where there's only 1 bone. And just over time, the thinking has shifted. So now, and the way paramedics are taught and the way they do it in the field, upper limbs only. Only 4 places that you put a tourniquet.
And you go all the way to the very top of the...
Go up as far as you can. As far as you can. Yeah. So again, if you didn't go up all the way, that's okay. You know, if you didn't get it all the way up. But if you needed to put a second tourniquet on, try to go above the first one. If you can't get above the first one because you did go really high, then go below it. But get it close to the original tourniquet. So I'm going to demonstrate the tourniquet. I hate demonstrating with this type of tourniquet because how many of you have this?
No.
Yeah, you probably don't. Which is why I don't like demonstrating with it.
Yeah.
But I like demonstrating with something that you all have, and I'll do a short demonstration of that in a second. So what we want to do is we want to put the tourniquet. Shock.
You said it's difficult. How do you know?
Shock is difficult to diagnose. Shock is, when we're talking about shock, there's all different kinds of shock that affect different parts of our body in different ways. And shock in its simplest form, it's not the, oh my God, I have 6 matching numbers on my lotto ticket. It's not that kind of shock. Okay, we're talking about shock that is very, very dangerous. It's the body's inability to deliver blood to and from your vital organs. In the easiest terms to put it, it's the body's inability to deliver blood to and from your vital organs. And when that happens, and it's constant and it's not corrected, then your organs begin to systematically shut down, and it can lead to death. So we do need to deal with people who are going into shock, and trauma can cause people to go into shock. The main signs of shock, and this is what I want you all to remember. Remember these main signs of shock. We will talk more extensively about them. But if you remember these main signs of shock, RPMs, this is how we triage. So that's why I want you to remember it. Respirations, perfusion, and mental status. So we can tell if somebody is going into shock, or we can suspect that somebody is going into shock if they are breathing rapid and shallow. And you will recognize it if they're breathing rapid and shallow. It's just, don't do it for too long, people try to belly. Capillary refill, perfusion. Capillary refill is, I'll go into it more when we go into triage. But it is how your blood is it's your circulation, okay? And then a failure to follow simple commands, right? So if somebody doesn't understand what you're saying, they're looking at you like, what? Excuse my what? Excuse my what? And they're altered, right? So their mental status becomes altered. So symptoms of shock can be easily missed. Pay very, very close attention to the patients. Yes?
So the third one, the failure to follow, absent the other two, I might go to you're wasted, as opposed to you're in shock.
Not necessarily. We'll go more into it when we go into triage. Okay?
And by the way, we have Narcan in our emergency kit back there.
Good.
And if anybody can get some free Narcan, bring it.
It's so funny you said wasted because I would have thought stroke.
Okay. So how do if we suspect somebody's going into shock, how do we treat them for shock? So first of all, we want to maintain their body temperature. We want to maintain that body temperature. If they're on something really cold, get something between them and the cold surface. Same thing if they're on something really hot, get something between them and that hot surface. We want to maintain their own body temperature, not the temperature of whatever it is they're laying on. And if they are wet, get them out of the wet clothing. And then wrap them with a coat, blanket, whatever it is, shield them from the wind, and do not give shock patients anything by mouth. Nothing to eat, nothing to drink. It is very common for somebody who's going into shock to be very, very thirsty and beg for water. And if you give them that water, if you give in to them and you give them that water and you think that they are in shock, all they are going to do is throw it out. So do not give them anything by mouth. They can't do it. They can't handle it. So wait until they're more stabilized before you give them anything by mouth. So that is how we treat for shock. And now we're going to take a break, and then we're going to go into triage.
It's 5:40.
I was just going to say, before we take a break, I need an update on the score.